He is Dr. Jamin Patel, an epidemiologist at the US Center for Disease Control and Prevention. He did his bachelor degree in the University of North Carolina in biology and also environmental studies. He went on to do his PhD in global epidemiology at Emory University, close to CDC. And then he went on to do his PhD in infectious disease epidemiology at the University of North Carolina. And currently he is with the Surveillance, Innovation and Research team as an epidemiologist at USCDC in the Polio Eradication branch. So he'll be giving us an update on global and regional situation on polio. And as we all know, currently even in Malaysia, we have an outbreak of polio in one of our states and also close by neighbor in the Philippines and Papua New Guinea. So this talk will be very interesting. So now I would like to hand over to Dr. J. Patel. The talk is yours and the floor is yours. Go ahead. Thank you.
Perfect. Thank you, Dr. Good morning, good afternoon, good evening, everyone. Hope you guys can hear me. I'm clear. I'll just wait until my slides are up. Perfect. I think it's, yeah, okay, there we go. Okay, so I'll get started. So as mentioned, my name is Jamin Patel. I'm an epidemiologist at the US Centers for Disease Control in the Polio Eradication branch. And today I'll give you guys a brief update on the global polio situation and then the regional updates for CRO and WIPRO regions. Next slide. Yeah, so this is briefly sort of my outline for my presentation today. I'll start out with some background on polio, and then we'll give an update on the global update in terms of the wild type polio virus, as well as the vaccine derived polio viruses. And then we'll briefly talk about an important development in our fight against polio, which is the novel oral polio vaccine for type 2 virus. And then I'll move into regional polio updates for CRO and WIPRO, and then round off with a discussion for next steps for the Global Polio Eradication Initiative, and then take your questions. Next step. Next, yeah, that works. So as many of you already know, poliomyelitis is a vaccine preventable disease. There are 3 serotypes, types 1, 2, and 3. It is transmitted person to person via fecal oral route. Humans are the only known reservoir so far. And though in rare cases, we have documented respiratory transmission. And so polio is a typical iceberg disease where less than 1% of the infections result in paralytic disease. Infection from poliovirus can only be established through laboratory confirmation via testing for stool specimens. And so poliovirus sheds intermittently through the stool, and the shedding peaks 14 days post-infection, but can be detected until 60 days post-infection. And so it is on a curve where the highest probability of detecting poliovirus during the intermittent shedding is within 14 days of post-infection, although you can detect the virus in the stool specimen until 60 days. So there's no cure for poliovirus, and so prevention is highly important. And our main tool for preventing polioviruses are the vaccines, which are very well known. Currently, we have 2 types of vaccines against polio. One, which is the oral live attenuated polio vaccine for all 3 serotypes. And then we also have the inactivated polio vaccine, which is injectable. Next slide. And so in 1988, the World Health Assembly adopted a resolution to globally eradicate poliovirus, and that's when they established a Global Polio Eradication Initiative, or GPEI. So the Global GPEI is a public-private partnership which is made up of 5 organizations: the World Health Organization, the US Centers for Disease Control, UNICEF, Rotary International, and the Bill and Melinda Gates Foundation. And the efforts to eradicate polio were largely focuses and leverages four main strategies. One is protecting children from polio by achieving higher routine immunization coverage, reaching previously unimmunized children through mass vaccination campaigns known as supplemental immunization activities, and then conducting mop-up immunization activities in areas with ongoing transmission or after the supplemental immunization activities are known as SIAs to ensure that every eligible child is vaccinated and protected. And then lastly, also very importantly, implementing a sensitive AFP surveillance system, which is, the AFP is the acute flaccid paralysis surveillance system, which is the surveillance system that is used to detect cases of poliovirus infections, as well as implementing environmental surveillance, which complements AFP surveillance that detects community circulation in communities. Next slide, please. And one more click. Perfect. Yeah. And so since 1988, when the resolution was adopted to eradicate polio, we've made significant strides towards that goal. As you can see in this graph, where we have polio cases on the y-axis and years on the x-axis, we have seen greater than 99% reduction in wild-type poliovirus or WPV. And some of the major milestones that we have hit along the way since 1988 are displayed on this graph as well. Like, for example, the last type 2 polio case that we saw in the world was in 2000. The last case in India, which used to contribute a significant bulk of the polio cases every year, was seen in 2011. And then we declared type 2 eradicated in 2015. And subsequently, an important step that happened at that point was in 2016, we withdrew type 2 vaccine virus from, at that point, the trivalent OPV, which contained all three types, and then switched from the trivalent type to the bivalent OPV. And this was done in a globally synchronized coordinated switch, where in April of 2016, we sort of pulled out all the type 2 containing vaccine viruses. And then in 2019, we declared type 3 as eradicated. And then lastly, with the most recent milestone that we've hit is we have certified Africa as wild-type polio-free. So we have made a lot of progress towards eradication since the resolution was adopted. Next slide, please. So let's look at the latest global picture for poliovirus. Next slide. So once Africa was certified polio-free, we currently have 2 countries that remain endemic for wild-type poliovirus, Afghanistan and Pakistan. And so as you can see from these maps that are generated by WHO on a weekly basis, in the last year, specifically in 2020, we did see several wild-type cases reported both in Pakistan and Afghanistan. These cases were these were human cases, as well as several environmental surveillance detections containing wild-type polioviruses were reported. However, in the last 6 months, and since the beginning of 2021, we have seen only 2 human cases so far reported from the endemic countries. But at the same time, we have continued to have wild-type poliovirus being detected through the environmental system. Next slide. And so quickly before I start on this slide, one thing that I wanted to introduce to people who may not know. So vaccine viruses in the oral polio vaccine contain live attenuated versions of those viruses. And sometimes the viruses can revert to regain the neurovirulent properties and cause paralytic polio. And these viruses can spread among populations and really cause paralytic polio among populations that have low immunity. And they're called vaccine-derived polioviruses. And so the picture for vaccine-derived polioviruses, or VDPVs, is quite different than what I just showed in the previous slide with regards to wild-type poliovirus. So compared to wild-type poliovirus, over the last year, and actually over the last few years, probably since like 2017, 2018, we started to see, we've seen several VDPVs emerge and circulate widely across the world. Mainly, we have seen a large number of countries in Africa that have experienced massive circulating VDPV outbreaks. At the same time, we've also seen a number of Asian countries report VDPV outbreaks and be affected. As the moderator mentioned at the beginning of the talk, we have seen outbreaks in Papua New Guinea and Philippines. Malaysia has seen some, Indonesia, Myanmar. So we've kind of have that problem in both Sierra and Vipura regions as well. And this kind of trend has continued over the last year, as you can see in these maps as well. Next slide. So with the rise of VDPVs, WHO did a recent risk assessment, and that risk assessment showed us that even despite the gains that we have made, there are large parts of Africa and even parts of Asia that remain at risk for these poliovirus outbreaks. The risk outside of the endemic countries still remain mainly due to VDPVs, and particularly VDPV type 2. And so as you can see on the graph on the right, where polio cases are on the y-axis, the years on the x-axis, and then the bars are color-coded by the different types of polioviruses that are being detected. You can see that VDPVs have been around for a while and have been detected at very low levels for quite some time. But starting in 2017, we did start to see a rapid emergence and spread that I mentioned in the last slide. And this was, I think, still, it's a combination of multiple factors that has led to sort of the rise and spread of VDPVs, specifically type 2 VDPVs across Africa and even in Asia. Next slide. And so as VDPVs emerged, it became clear to the GPEI, to the global program, and to the scientific community that we would need to develop a solution that would need to address this issue of vaccine viruses reverting to regain its neurovirulence properties and causing these paralytic polio cases. So efforts were then underway to develop a new oral polio vaccine that would limit the reemergence of these VDPVs. And those efforts were first sort of focusing on type 2, as those were the ones that were causing majority of the VDPV outbreaks. As you remember, that type 2 was the vaccine that was taken out of the circulation from the trivalent vaccine. And so a new vaccine that was developed, a novel oral polio vaccine for type 2, is a modified version of the current OPV that we already have. But it has been designed to have increased genetic stability, which reduces the reversion to its neurovirulent state. And at the same time, the vaccine that has been developed also reduces the risk of seeding new VDPVs and reduces the risk for vaccine-associated paralytic polio. And so this new vaccine, NOPV2, has gone through extensive clinical testing, has gone through all the 3 phases of clinical trials. And then in last year, in November 2020, the vaccine was given the WHO's approval for emergency use listing, and plans were underway to start using NOPV2 as a tool to combat VDPV type 2 outbreaks. And then an update, a recent update just last month, WHO, SAGE, which is the vaccine advisory group for WHO, actually endorsed a much wider use for NOPV2 outside of its EUL categorization. Next slide. So as I mentioned, NOPV2 will be one of the primary tools that we will be using to combat these CVDPV outbreaks across the world. And countries have started to gear up and implement the vaccine, but they must first meet a set of sort of implementation criteria that GPEI and the global polio community have developed to ensure the proper rollout of a new vaccine, to ensure that the right safety protocols are in place, the right surveillance measures are in place to detect sort of any activity or any circulation that might be going on. And so currently, out of those risk assessment countries that were deemed at risk, from the risk assessment, 38% of the countries have already been verified and approved for the use of NOPV2, and 47% of those countries are currently in the process of meeting those readiness requirements. And so far, close over 130 million doses of NOPV2 have been used in the initial phase in 7 countries, 6 of them in Afro and 1 of them in Euro. However, as you would expect, this is a new vaccine. We still are dealing with widespread, we're still dealing with the issue of limited NOPV2 supply. And we think that this supply might be an issue for probably a few more months to a year. And so in that setting, every country that is applying to use NOPV2 has to get approved from the steering committee and the global polio, sort of the AG as well. Next slide. So moving on to regional polio updates. Next slide. Starting with the Sierra region, as you know, the Sierra region was certified polio-free in 2014 after the last case was detected in 2011 in India. And since then, no wild-type cases have been reported. However, the region has not been free of VDPVs. We have seen detections and outbreaks of VDPV type 1 and type 2 in several countries, as indicated on this map and the table here. And the risk of VDPV remains present, specifically for type 2, as now we're more than 5 years out from the global switch, and the pool of susceptible children who have no type 2 immunity increases if they have not gotten the IPV vaccine. Type 2, next slide. And so looking at the polio vaccine coverage in the region, overall, the region has actually done pretty well in terms of getting its polio vaccine coverage high, as you can see in the map on the left, which is displaying the 2020 WUNIC estimates, which are the WHO UNICEF poll 3 coverage across the regions. Generally, the coverage has been pretty high. And even for the oral polio
vaccine. Please. This is the test. This is the test for emergency alarm system and emergency broadcasting system. This is only a test. お客様にお知らせいたします。お知らせいたします。
Sorry guys, we're in a hotel that is having some tests.
繰り返しお知らせいたします。安全性のため、今から火災警報器のテストを行います。どうぞご了承くださいませ。ありがとうございました。各位贵宾请注意，这是安全试验。现在进行的是我们广播及警报系统的安全测试。
Yeah, sorry for that, Patel.
Yeah, sorry guys.
请各位同事到适当广场集合。
Alright.
Attention, please. This is the test.
Apparently, we need to do English twice.
For emergency alarm system and emergency
Sorry about
broadcasting system. This is only a test. お客様にお知らせいたします。今から火災警報器のテストを行います。繰り返しお知らせいたします。
I think we are okay now.
I think, yeah.
Yeah.
I'll try and continue, and if it, okay, perfect. Seems like we're good to go. Yeah, so the main point that I was trying to make on this slide was that overall, I think the coverage has been good over the years. However, as you can see from the graph on the right, which reports the OPV3 coverage, you can see in 2020 there was a dip in the coverage, and that is likely the sort of the impact of COVID-19 pandemic that we have all heard and seen its effect on sort of regular health programs. Next slide. And so quickly looking at the AFP surveillance performance across the region. So when we talk about acute facet paralysis surveillance, which is the system that's used to detect poliovirus among human cases, there are two surveillance performance indicators that are used to assess the quality of the surveillance system, of the AFP surveillance system. The first is the non-polio AFP rate, or the number of NPFP, which is non-polio AFP, cases per 100,000 children under the age of 15 per year. And so the global standard for a non-endemic country of an NPFP rate of 2 greater than or equal to 2 cases per 100,000 is considered sufficiently sensitive to detect any circulating polioviruses that might be in the communities. And so as you can see in this graph, the NPFP rate for sensitive surveillance systems was met at the regional level across NCRO, but you could see some of the fluctuations that were observed over time in individual countries. And specifically, you could see in 2020 and 2021, again, where COVID-19 had just impacted just pretty much about every aspect of our lives, including health systems and surveillance systems as well. And also you could see the sort of the within the year fluctuations over the years across the region on the graph on the left. Next slide. And so the second surveillance indicator to sort of assess the quality of AFP surveillance or polio surveillance in a country is sort of adequate stool samples that are collected, because if you remember, poliovirus requires a laboratory confirmatory test, and that is done by testing stool specimens. And so the indicator is collecting 2 stool specimens collected 24 hours apart at least, and within 14 days of paralysis onset, and arriving to a WHO laboratory in good condition. And so this indicator essentially ensures that there's adequate sensitivity and adequate or the highest probability of virus being in the stool specimen if it is a positive case, and it being detected through laboratory test. And so similar to NPFP rate in CRO, you could see that the stool adequacy across the region performed pretty well. This is for 2020 and 2021. But there were, again, variations noted within countries across the region. Next slide. I think there's one more. Yeah, okay. And so at a recent Zero Regional Certification Commission for Polio Eradication meeting, which was actually just last week, the group actually outlined strategic priorities for polio elimination in the region. And these priorities include increased government ownership and accountability in polio activities with clarity and urgency to responding to CVD-PV2 challenges that may arise in the region. A big priority was in improving AFP surveillance and maintaining those sensitive AFP surveillance systems across the region for rapid outbreak detection and response, with specific focus on reducing laboratory sort of reporting time and routine analysis of surveillance data to track the quality of surveillance indicators, whether or not the system is up to snuff in terms of detecting any potential polioviruses that might be circulated. And lastly, the group also agreed on the importance of conducting routine risk assessments in countries and planning to ensure an optimal outbreak response. Next slide. And so now moving over to the Western Pacific region, the Western Pacific region was actually declared polio-free back in 2000. And since then, it also hasn't seen any wild-type polio cases. However, like CRO, the region has seen multiple VDPVs over the last few years. And so from 2001 to 2012, like I had mentioned earlier, VDPVs were around and they were detected, but in small numbers, and they were mainly, at least in Western Pacific region, they were mainly from China and Philippines. However, since 2015, and also more so since like, I would say like 2016, 2018 onwards, we've started to see an increase in the number of VDPVs that are being detected across the region, with more countries also reporting these outbreaks and cases. And again, I think this is an indication of sort of population level immunity sort of dipping down because of the issues with routine immunizations, COVID pandemic happening. And so sort of those kind of all play into the factor for an increase of CVDPV outbreaks. Next slide. And so similarly, looking at polio vaccine coverage, overall large parts of the region were pretty good with polio vaccine coverage. As you can see in this map, these are the POL3 coverage, the WHO UNIC estimates that were reported for Wipro. However, you do see those suboptimal, any color besides green, suboptimal vaccine coverage in several countries in the Wipro region. And these actually countries a lot of them are the ones who are experiencing some VDPV outbreaks or have reported some VDPV detections. Next slide. And so kind of quickly looking at the AFP surveillance quality in the region, Wipro has actually done pretty well overall, meeting both surveillance indicators of NPAFP rate and adequate stool specimens over the last 5 years. And because of one of these reasons, a lot of the VDPVs that were circulating in the region were detected sort of fairly quickly, and we were able to respond to a lot of those outbreaks in a timely fashion. Papua New Guinea, Philippines, are a couple of the ones that come to mind where I was personally involved and in terms of sort of responding to those outbreaks. Next slide. And so at a recent technical advisory group meeting in Wipro, the member states sort of outlined their goals and targets for polio elimination. The regional goal is to eliminate all polio, including VDPVs, by the year 2030. And the target is 0 polio incidents from any poliovirus type. And the strategies that they identified that they were going to employ to achieve their target and meet their goals include sort of similar to what CRO had outlined, sort of achieving and sustaining high-level population immunity through high-quality SIAs and routine immunization. They do want to withdraw all OPV from use and immunize populations with IPV. They want to sustain high-level and highly sensitive polio surveillance systems. They want to make sure that there is sustainable domestic funding for essential polio functions and less reliant on outside sources. And then again, maintaining the prompt and thorough response to polio outbreaks. Next slide. Okay, so I think this is my last slide. And so lastly, sort of kind of ending on a global note, the GPEI has recently developed and approved a new polio vaccination eradication strategy, and this strategy is aiming to interrupt, as you can see on this graph here, which is sort of a little bit forward thinking. The plan is to aim to interrupt wild type 1 transmission and CVDPV2 transmission by end of 2023. And then 3 years later, by end of 2026, certify the interruption of type 1 and CVDPV type 2. And then the plan is to completely phase out BOPV by end of 2027 and aim to stop any VDPVs type 1 and type 3 by end of 2028, with certification happening somewhere 3 years after, around 2031 or somewhere close to after that. So that's sort of like the revised version of what we think the timeline would be to get to 0 if everything kind of holds true in terms of the rollout of the novel PV2 vaccine that we're really hoping is kind of, if we can use it in a timely manner to address, to sort of respond to these outbreaks. And so to conclude, I think while we have made significant strides towards polio eradication, I think our job is not yet done. We are very close, but I think there's still a significant amount of work that's left to be done. And I think we owe it for all the sort of the people who are affected by polio to kind of make sure that we cross the line and we really do get to zero in terms of polio eradication. So I'll stop there. Next slide, I think is this my thank you slide. So yeah, I'll stop there for, I know, turn it back over to the moderator. I don't know if we're gonna do questions right away or are we gonna wait towards the end of the session. So thank you.
Yeah, thank you, Jamin Patel. Yeah, that was very informative to all of us, especially now the new updates. Yeah, we have one question coming from Dr. Yudi Wibowo from Indonesia FETP. He's asking, during the COVID-19 pandemic, routine vaccine coverage, including opinion regarding this and what is the impact and what do you think we should go about doing that?
Yeah, I mean, I think polio definitely was affected by the pandemic, but I think it wasn't the only disease. I think we're seeing the effect of the pandemic across all vaccine preventable diseases. But speaking from the polio perspective, I know just generally in Asia and Africa, because the routine immunization services were impacted quite a bit, and also the supplemental immunization activities, they were pretty much just halted. I think that gave the virus the opportunity to kind of keep circulating, and we weren't able to stop circulation in a lot of these communities, and the scope of some of these outbreaks have grown, and in some cases the viruses have even been introduced or imported to different countries or different geographies. And again, I think all of that to say is just like, it's just making a lot of the progress we made, it's reversing a lot of the progress. So I think as we come out of this pandemic, or as we start to ramp up our activities, we just need to kind of go stronger than before to make sure that we kind of regain all the progress that we made and then drive to zero after that.
Yeah, thank you. Yeah, we tend to agree with what now I think all of us have to relook and review back all our vaccine preventable diseases and see what they are. Yeah, yes, very true. Yeah, I see one hands up now from Dr. Haryadi Wibisono. You have anything to say, Dr. Haryadi?
Yes,
questions? Yeah.
Thank you, Dr. Fazila. And I appreciate what Dr. Patel presentation. I would like to have Dr. Patel opinion in this, because as everybody knows that due to the COVID-19 pandemic, most like Dr. Fazila mentioned, most all other program has been declining. But I'm focusing on discussion of the polio. As you mentioned, only 1% cause the paralytic. It means 99% of the polio case without paralysis. So when we have to find the polio cases through the non-polio AFP surveillance during the pandemic, it's a very big challenge for almost all countries. And I am focusing on in several areas where the coverage of OPV is quite low and the performance of surveillance also low. It means the risk of VDPV is getting bigger and bigger. My question now is asking your opinion. On the other hand, we need to have a strong environmental surveillance. But the question, how to make an appropriate site to have a good quality of environment surveillance. We have the indicator, the non-polio enterovirus as an indicator. But again, I can see that most from the environment surveillance is not appropriate site, because the rate of non-polio enterovirus is quite low. My second comment is regarding the novel OPV2. I know that this is going to be a big production of the vaccine. But as our experience with IPV last time, that there's some limitation of the stock global wide, and also the race of stock out of NOPV2 also we cannot expect it. But as a big country like India and Indonesia, the problem of distribution is also another challenge. Most of the remote area is challenging to distribute sufficient novel OPV2 if needed. Thank you, Dr. Patel. Thank you, Ibu Hasila.
Yeah, thank you, Haryadi. Very, very good question. Yeah, I think as an environment specialist too, Jaymin, you sure can answer it. Yeah.
Yeah, and I agree with all the points that were made, and especially when it comes to environmental surveillance. I know there are guidelines that are in draft, and I can find out and follow up on the status of the exact guidelines and SOPs for environmental surveillance and where they are, and circle back with you. But I completely agree. I think the selection of environmental surveillance sites is a very important decision to make sure that you're sampling at a site that actually is representative and captures sort of the population that you want to surveil, because when the outcome is rare and when you're starting to see low number of actual human AFP cases, surveillance, environmental surveillance can be used to complement or supplement rather AFP, conventional AFP surveillance. And so, yes, I agree. I think it has to be done in sort of collaboration with the environmental surveillance experts and make sure that we're really getting to the representative population that we want to surveil. And then quickly about NOPV2, I think because it's a new vaccine that has recently been licensed and is starting to get the right set of approvals, and given that Afro is just experiencing CVDP outbreaks at such a unprecedented massive level, I think its demand right now is completely on a different scale than the supply is. But we're hoping that very soon or in the near future that supply will catch up to demand and we can start to use it in addition to our to combat the CVDP outbreaks. At the same time, if we effectively use monovalent OPV vaccines and actually achieve true high coverage, they're also still very effective at stopping transmission, because I think that's one of the reasons we keep using oral live vaccine, is because it not only helps protect individuals, but it helps stop transmission. And that is sort of the key of an outbreak response, right? And so, yes, novel or OPV2 is a great tool that's coming up in the horizon, but we still have monovalent OPV that, if used properly, if achieved high coverage, it will stop outbreak. So, thank you.
Yeah, good. Yeah, we have another one coming from Conchi herself. Thank you very much, Jaymin, for your very informative update. Could you say something regarding IDPV2 cases? As you know, there is a case in the Philippines that continues to shed the virus, and unfortunately, the child did not respond to the initial treatment with the antiviral drug. So what is the plan for dealing with such cases? I mean, this is just one of the many cases that we are seeing now.
Yeah. And so, and I think, to be honest, like, I'm not the biggest expert on IVDPV, and to my knowledge, using the antivirals that were sort of approved, because I actually know of that case in Philippines, and I think there's one in Pakistan as well. And I would have to revert back to my colleagues who are working on IVDPV to know what would be the next steps, because I think there's a lot of discussion happening as we get to these last few cases. IVDPVs are going to become more and more important because they're going to continue shedding the virus and they're not going to respond to the vaccine. And if they're not going to respond to treatment, then I think we're going to have to to come up with some solution or some alternative way to kind of to get at that. So, but sorry, I don't have the answer right away. Follow up with you.
It just says that you need to still work at your polio. Okay, that's one more. I think you did answer this in your talk, but just to respond to Lawal Amadou, he says the NOPV2 introduction was very successful in Nigeria, and so he wants to know what about the other regions in the world.
So right now, only one country in Euro has introduced it because they have readiness criteria, and there's a few countries in Africa that have used it. And so what happens is once a country has experienced an outbreak or an BDPV2 case, they have to submit, there's a checklist of criteria that they have to meet to be able to introduce NOPV2. And this is largely because the vaccine is still under an EUL categorization. And as a global, as a polio program too, we want to make the right safety programs are in place, the right surveillance measures are in place to make sure that we're detecting any sort of safety issues that are coming up, any virus circulations that are happening out, any breakthrough cases that are going on. So the countries have to have these mechanisms in place for us to approve the use of NOPV2.
Yeah, and also just my own curiosity following that. As you can see, 7 countries in Afro and 1 country in Euro, but none in CRO and WebPro. Why was that? Is there any criteria, categorization of choosing the countries?
No, so I think there is a priority categorization, but I think largely it is because if I remember correctly, the Philippines outbreak has been closed, and I think I feel like majority of those outbreaks in Syria are closed right now. I think Malaysia is supposed to come off the board.
Yep.
Has been a while. They have done the appropriate responses. Then I think close.
I think it's after the evaluation. And it was
So the right actions have already been taken, and so I don't think there are any campaigns planned. And so I think I'm trying to think of I don't think there is any active
cases going on.
Outbreak response going
on.
So
I think that's Thank you so much. Sorry, that's one more last one. From Nohaida Ujang EIP Malaysia. So during this COVID-19, we in the district do not see any AFB cases in the hospital. Thus, no stool specimens can be adequately taken. So in fact, none. How are we to comment or interpret on the performance of the AFP surveillance and how to relate to detection of the polio situation in the area? That's a very good question there.
So I think if you're asking the question of that COVID has impacted surveillance systems, that is hard to, and I think we're seeing that all across. Pro and Sierra are not the only regions. Afro has seen all across the board. We have seen AFP surveillance quality go down. The NPFP rates have been going down. Quite a few countries and regions, and so that's not to say that the AFP surveillance system in that country is not working. It's just that's a reality, and I think as we do get out of this pandemic, we need to get back those systems up and again. So we make sure that any virus that's in circulation that we get. Thank you so much, Jamin Patel. That was a very good and very informative to all of us on polio situation and updates. Thank you. Applause to you and everybody, please. I don't know, it's closed, so we cannot give you a clap or something. That's fine.
Okay, but it was very good. Thank you so much.
Thank you.